recording.
Hello, everyone. Welcome to part 2 of our 3-part series. This second part, we are going to be talking about opioid use. So first of all, we're going to speak on prevalence of opioids. So opioids have seen a huge increase in prevalence in the last 3 decades. Many of us have lived through this huge social shift from opioid aversion to very liberal prescription of opioids for management of pain. The CDC reports large increases in prescriptions starting in 2006, with the highest being 259 million prescriptions written for opioids in 2012. While these numbers have since been decreasing, the number is still staggering. In 2019, there was over 153 million reported opioid prescriptions, or 46.7 prescriptions per 100 people. Of these people being prescribed opioids, approximately 20% report using these prescriptions for non-medical reasons.
All right, so now I want to take this time to get into the mechanisms of opioids a little bit. So opioids act upon one of 4 receptors: the mu receptor, the kappa receptor, the delta receptor, and opioid receptor like 1. The mu receptor is responsible for most exogenous opioid binding. It is responsible for modulating the body's pain response using endogenous opioids, such as beta endorphin and enkephalins, but its effects are increased dramatically when stimulated by exogenous opioids. In addition to its analgesic effects, it is a mood enhancer, invoking feelings of euphoria and sedation that are particularly appealing to those with psychological comorbidities on top of their chronic pain. In the short term, opioids are proven to be extremely effective in reducing a patient's pain experience when used in acute situations such as surgery or traumatic injury. However, in the long term, these effects are more limited in terms of being an analgesic agent, on top of an increasing risk of side effects correlated with a higher dose and longer treatment cycle. Opioids have a variety of serious and potentially life-threatening long-term side effects. Although they are clearly strong, effective, and mostly safe in the short term, their waning effects in the long term, combined with a long list of potential side effects, makes the efficacy unclear in terms of treating the long-term chronic pain patient. Much like the reward deficient states experienced by the chronic pain patient, chronic opioid users find dopamine and opioid-mediated liking of normal rewards such as food and sex diminished, entering this reward deficient state, much the same as someone in chronic pain who isn't on opioids. When a chronic pain patient takes opioids, the reward deficiency associated with things such as reward and salience associated with chronic pain are decreased, setting up the chronic pain patient for an increased risk of addiction to opioids. So we're going to dive into 5 major consequences of long-term opioid use, including a decrease in control-matched functional outcomes, the phenomenon known as opioid-induced hyperalgesia, increasing tolerance, opioid use disorder, including misuse, abuse, and addiction, and finally, opioid-induced respiratory depression, also known as an overdose. Kidner 2009 addresses that most patients had sustained soft tissue injuries, including a few fractures and dislocations, as well as soft tissue joint procedures and some spinal surgeries. Orthopedic surgeons agree that the majority of patients undergoing such procedures are unlikely to have sufficient permanent tissue damage to warrant chronic opioid use. This means that these decreased functional outcomes are not only a result of a more severe injury alone. By 6 months following the procedure, the biopsychosocial factors play a major role in the maintenance of pain and disability, with the original nociception playing a more subordinate role. As such, the biopsychosocial model of pain views the initial injury as only tangentially related to chronic pain and disability issues. As such, this alone cannot explain why these patients experience less successful outcomes. This suggests that the opioids themselves may play a role, but as correlation does not imply causation, it is impossible to make that claim with any certainty. In terms of return to work and disability, the same trends hold. Regardless of initial injury severity, the group with a higher post-injury opioid dose was associated with a greater risk of program non-completion, in addition to statistically significantly lower rates of return to work, work retention, and higher healthcare utilization. After 1 year, The group reporting the highest opioid use was 11.6 times more likely to be receiving Social Security disability as compared to the no opioid use group. The next side effect I want to talk about is opioid-induced hyperalgesia. Opioid-induced hyperalgesia is characterized by a paradoxical response, where a patient receiving opioids for pain could become more sensitive to certain painful stimuli. It's defined as the state of nociceptive sensitization caused by exposure to opioids. Although findings of clinical prevalence for OIH are not available, observational, cross-sectional, and prospective control studies have examined OIH in humans. The precise molecular mechanism of OIH is yet to be understood, but OIH should be on the clinician differential diagnosis list when opioid treatment effects seem to wane, especially if the patient presents with emerging allodynia, defined as pain due to a stimulus that does not normally provoke pain. Alongside this, increased levels of pain with increasing dosages are observed in opioid-induced hyperalgesia. This graph does a good job representing the idea that at initial use, a patient's pain tolerance sees a sharp spike as the analgesic effect of the opioids is in full swing. Eventually, however, a patient suffering from opioid-induced hyperalgesia sees that high level of pain tolerance wane, even while on opioids, to a point where they are taking their opioids in order to avoid being in more pain rather than taking away their pain altogether. It's important to separate OIH from tolerance. According to Clark and Eng's 2006, exposure to opioids can result in a need to increase the dose over time to maintain the desired analgesic effect. Typically, this has been attributed to the development of tolerance. However, dose escalation can also be expected as a result of OIH. Pharmacologically, tolerance is characterized by a loss of drug potency or a right shift of the dose versus effect relationship seen in the top right, while OIH is characterized by increased pain sensitivity or a downward shift of the dose versus effect relationship. Tolerance reflects a desensitization of anti-nociceptive pathways, making the pathways that counter pain less effective, whereas hyperalgesia involves a sensitization of pro-nociceptive pathways, increasing a patient's pain experience altogether. Such a distinction is not trivial and becomes relevant when attempting to overcome a loss of treatment effect. Tolerance may be addressed by simply increasing the dose, whereas the same intervention may result in aggravated pain in the case of OIH. It is statistically likely that opioid therapy, particularly aggressive opioid therapy, has the potential to heighten pain sensitivity as well as aggravate pain. So now I want to get into opioid use disorder. In order to talk about opioid use disorder, we need to define a couple terms, including misuse, abuse, and addiction. The therapeutic success of opioids depends on proper candidate selection, assessment before administering therapy, and close monitoring throughout treatment. Can we predict who is at a higher risk of opioid abuse? And can we better tailor our interventions to reflect that? The answer to these questions are yes. Misuse is defined as the use of a medication for a medical purpose other than as directed or indicated, whether willful or unintentional, and whether harm results or not. Abuse is defined as any use of an illegal drug or the intentional self-administration of a medication, such as an opioid, for a non-medical purpose, such as altering one's state of consciousness, for example, getting high. Addiction is defined as a primary chronic disease involving brain reward, motivation, memory, and related circuitry that can lead to relapse and progressive development that is potentially fatal if left untreated. Markers include craving and continued use despite adverse outcomes. This definition is much the same as the criteria for opioid use disorder, the continued use despite adverse outcomes being the one part to focus on the most, in my opinion. Things such as the persistent desire or unsuccessful effects or efforts to cut down or control opioid use, a lot of time spent obtaining, using, or recovering from the effects of opioids, recurrent opioid use resulting in a failure to fulfill major role obligations at work, school, or home, and common use that gets in the way of social or interpersonal problems. It's defined as continuing use despite knowing that all of these problems are occurring in your day-to-day life and being unable to stop your use of the drug despite all the negative consequences of your use. Now, talking about addiction specifically, according to the CDC, the majority of opioid users do not get addicted. However, the rates of opioid addiction are statistically significantly higher than rates of other prescription medication addiction, addiction being defined as the most severe form of a full spectrum of substance abuse disorders. The rate of overdose deaths due to opioids in 2016 was more than 3 times the rate in 1999. And the rate of drug overdose deaths involving synthetic opioids other than methadone doubled from 3.1 per 100,000 in 2015 to 6.1 per 100,000 in 2016, with half of those deaths directly attributable to the synthetic opioid fentanyl, a cheaper alternative to heroin. The incidence of heroin initiation was 19% higher among those who reported prior non-medical pain reliever use than those who did not. And 86% of young urban IV drug users had used opioid pain relievers non-medically prior to using heroin, either through friends, family, or even their own personal prescriptions. Talking about the mechanisms of addiction a little bit, the nucleus accumbens responds to dopamine with feelings of reward, motivation, and salience. As we discussed, in chronic pain patients, these feelings are diminished as the nucleus accumbens and the prefrontal cortex eventually transition to this hypodopaminergic state. These pathways are very similar to what we see in addiction. With initial drug use, dopamine projects from the frontal brain to the nucleus accumbens, creating strong feelings of reward, motivation, and salience, while at the same time increasing glutamate levels that form memories relating to this now hyperdopaminergic state to this initial drug use. This is particularly notable for chronic pain patients who at baseline experience reduced feelings associated with the nucleus accumbens and as such likely perceive the increased feelings of reward, motivation, and salience more so than somebody taking an opioid who is not in chronic pain. In time, we see the same phenomenon we see in chronic pain patients. The levels of dopamine production and dopamine receptors decline, requiring more of the drug to invoke the same feelings as before. And in the meantime, reducing the user's ability to experience these positive feelings at baseline without exogenous drug use. This can create a vicious cycle to those predisposed to reward deficiency at baseline, such as chronic pain patients. Acute drug abstinence after a period of regularly taking the drug leads to side effects such as negative motivational states, general discomfort, dysphoria, and stress and anxiety. This is known as withdrawal. The body's endogenous ability to bind and release opioids is decreased due to existing in a long-term hyperdopaminergic state as a result of exogenous substance use, which means these exogenous substances are some of the only way for these users to experience normal feelings of pleasure and reward. As such, the effects of not using exogenous sources of dopamine become increasingly pronounced. Long-term users need more exogenous sources of dopamine, in this case opioids, to create the same effect, while at the same time increasing the side effects of acute drug abstinence. The final side effect we're going to talk about today is opioid-induced respiratory depression, a sometimes fatal complication of high doses of opioids, also known as an overdose. Opioid-induced breathing alterations are complex, but can be characterized by hypercapnia, reduction in tidal and minute volume, and slow irregular respiration. At high enough doses, and if left untreated, this can lead to a fatal apnea. When used in an acute care setting, the risk of death from OIRD is slim due to careful prescription of opioids and widely available access to the opioid receptor antagonists such as naloxone, occurring in 0.5 to 2% of patients according to Boom et al. In 2012. Naloxone directly counteracts the analgesic effects of opioids at the same time, making it a necessary yet unpleasant experience for those showing signs of ORID in a postoperative setting. Those who misuse and abuse opioids have less access to opioid receptor antagonists and are less likely to be supervised at the time of their opioid consumption. They do not have an outside mediator of their dose or someone monitoring their vital signs in case of an emergency. This leads to a higher likelihood of severe complications such as fatal apnea resulting from opioid-induced respiratory depression in the recreational population. The rate of national overdose deaths involving any opioid has more than quadrupled between 1999 and 2019. It is possible to predict who is most susceptible to both abuse opioids and suffer from overdose. For opioid-induced respiratory depression, some predictors include substance abuse disorder diagnosed in the previous 6 months. This is also the strongest predictor. Other predictors include bipolar disorder, schizophrenia, cerebrovascular disease, concurrent benzodiazepine or antidepressant prescription, sleep apnea, recurrent headache, daily morphine equivalent dose over than 100 milligrams, and extended release and long-acting opioid formulations. As you can see, many of these predictors are psychological, suggesting even more so to the link between one's psychological well-being, their pain experience, and their eventual outcomes.
Now for some risk factors of opioid abuse. Genetic susceptibility increases vulnerability to drug addiction, as well as younger age of the patient due to decreased development of their frontal lobe, as well as being female. Abuse of other substances puts people at larger risk, as mentioned earlier, as well as mental health disorders. Opioids can actually reduce symptoms of anxiety and depression in the short term, but this leads to reliance and dependence in the long term, leading to difficulty in ceasing opioid use. Chronic pain can aggravate these mental health comorbidities and vice versa, creating a vicious cycle of pain and decreased psychological well-being. Chronic pain patients with comorbid depression or anxiety are more likely to experience more persistent pain, low quality of life, and higher opioid doses compared to controls. Typically, it's not just one risk factor alone, but possessing two or more risk factors that puts people at highest risk for opioid abuse. Lastly, a well-studied risk factor for abuse is patients with chronic pain. A 2019 systematic review states that patients with non-cancer chronic pain are at large risk for abuse. In two meta-analyses, it is estimated that the prevalence of chronic pain patients using prescribed opioids non-medically is 48 to 60%. Overall, patients who suffer from chronic pain are at a huge risk of abusing the very thing that they have been prescribed to help them. And now for the burden of care, there's a huge cost associated with opioid use. But NIH estimates the economic burden of opioid misuse is $78.5 billion per year. This number comes from cost of healthcare, loss in productivity, treatment for addiction, and criminal justice involvement. The mean direct healthcare cost for patients who abuse opioids is 8.7 times higher than non-abusers. These patients are 4 times more likely to utilize medical services such as the emergency department, 11 times more likely to use physician or mental health outpatient facilities, and 12 times more likely to have inpatient hospital stays. Opioid therapy has been described to increase disability and cost of care. A 2014 study of over 9,000 patients reported that prescription opioid users, on average, miss 13.3 more days of work because of disability or medical absenteeism annually versus non-users. Overall, opioid use is a huge economic burden both to patients and to the healthcare system. So this leads to the question, why are we still prescribing opioids? If we possess all of this information about the consequences and the potential detrimental effects of opioids, why are they still being prescribed in such large numbers? The CDC's first recommendation for chronic pain is non-pharmacologic therapy. And if you choose a pharmacy option, they recommend non-opioid therapy. Furthermore, when someone has been prescribed opioids, they suggest continuing to monitor its use and to discontinue it if there's not clinically meaningful improvement in pain and function that outweighs risk to patient safety. Overall, the benefits do not outweigh these risks. So the question remains, what is another solution for chronic pain?